Evening, we are gathered here to discuss two interesting real-life case studies, and our expert panelist, our moderator and our course director, sir, will bring out a lot of discussions and pearls of wisdom through these real-life cases. It gives me a honor and privilege to welcome our course director, Dr. Subhash Kaul, sir. Sir is a senior consultant and stroke specialist at AIIMS Foundation and Research Center, Secunderabad. Sir has more than 3 decades of experience working as a faculty in Nizam's Institute of Medical Science, one of the prestigious institute of the country, and a former professor and head of the Department of Neurology, and also a dean at NIMS. Sir has hundreds of publications on his credit, and he has been a part of many groundbreaking clinical trials, including Hyderabad Stroke Registry funded by ICMR. Sir has been a past president of Indian Stroke Association, Indian Academy of Neurology, and also Andhra Pradesh Neuroscientist Association. And in addition to that, sir has been always a mentor to us at MCure and a friend, philosopher, and guide to conduct various programs and scientific activities. And this is one of his visionary activity, which we are doing for last more than 2 years. At the same time, it gives me a privilege and honor to welcome and introduce our esteemed moderator for the day, Dr. Meenakshi Sundaram, sir. Sir is a senior consultant neurologist at Apollo Hospital, Madurai. Sir has more than 20 years of experience in neurology and presented many papers at various prestigious national and international forums. Sir has received a Best Research Paper Award at 10th Annual Conference of Indian Academy of Neurology in Lucknow way back in 2002. Sir has also been a part of many clinical trials comprising of a refractory partial epilepsy, stroke, acute stroke intervention trial, and PD trial. Sir has been an editor for South Asian edition of book Practical Neurology, and he has contributed to many books and the chapters in the field of neurology. And interestingly, sir has been a part of clinical trials involving Tenecteplase in a stroke. Thank you very much, sir. Sir has also been joining us for last more than 2 years, continuously moderating the sessions and bringing a lot of discussion points, which is really very important at real life scenario. I would also like to welcome our moderator, Dr. Makarand Kanzalkar, sir, from Aurangabad. Somehow, because of exigencies, he would not be able to join. He's a director and consultant neurophysician at Manik Hospital and Research Center at Aurangabad. Now, I would like to welcome our esteemed speaker for the day, Dr. Govinda. He is a consultant neurologist at Sri Krishna Neuro Specialty Hospital at Nirmal City in Telangana. And he previously worked with, he is alumnus of a prestigious All India Institute of Medical Sciences Neurology Department. And he has closely worked with Dr. Professor Mendi Ratta, sir, at Janakpuri Super Speciality Hospital and also All India Institute of Medical Science. I welcome you, sir. I would also like to welcome our second speaker for the day, Dr. Nandini Priyanka. She is a consultant neurologist at Apollo Hospital, Trichy, and she has been an alumnus of Tanjavur Medical College and Chidambaram Annamalai Medical College. She has completed a specialized training in the epilepsy, stroke, dementia, and Parkinson's disease involving advanced medications and non-invasive brain stimulants. She has published many papers and achieved many appreciation for her work in these area. I welcome Dr. Nandini as well. So with this smart introduction, I would like to stop here. Just a second. Okay, so I will just stop. So, sir, Dr. Meenakshi Sundaram, sir, till sir join, would you like me to just walk through 3-4 slides of recent development which has happened and which is really very exciting to all of us?
Sir, it's a pleasure to listen to those wonderful advancements. We are waiting to hear.
Called as last month, and that's what I thought I will just share till sir join, and maybe we can initiate our discussion with this positive, what you call as a development or the recent development, I would say. And maybe, sir, your expert comments, and then we can go ahead with the case, sir.
Yeah, really, they are very exciting things. After the ACT study, And in fact, we could say that even before the ACT study, we were completely, compelled to believe in Tenecteplase, which we are using. And the point which you also raised is also relevant here, because when we say low quality evidence, it doesn't mean the evidence is of low quality. It only means that there is only one or two studies now. More studies have to come. When they get published, now the recommendation changes to high quality. Just that we are waiting for more studies. It should not be interpreted that the evidence is of
Yes,
low
yes,
quality.
yes, yes.
And after the ACT study, the ACT study said Dr. Vijay K. Menon and the group from Lancet, from Canadian group, they published it. There was an expected data only which said that they are equal in 1:1 ratio. That was expected. And ever since the Tenecteplase TNK2 trial was published, we are always convinced that it should be used more often in centers where mechanical thrombectomy is available, because that gives an edge for us. Because earlier we used to give altiplase, the infusion would be running when we are actually taking the cath lab, or we had to wait for it to get over. Sometimes we do an angiogram subsequently later. So many things we evolved over time, the understanding of this. Now we have no waiting period at all. You just give the patient Tenecteplase and then take. And the latest recommendations is don't even wait for any improvement. If there is an LVO, when you are given Tenecteplase, you take them to the theater. You can find out there whether the vessel is open or not. If
Yeah,
it is open, you come out, which is more often the case. The Bruce Campbell study showed that more often the case, the vessel opens up. So these are all really exciting things. And I should also tell this audience that after the data which came from China, which talked about an extended window for up to 24 hours, it can be used. And India has also taken up the study from Delhi AIIMS. They have taken up the study to look into this extended thrombolytic window. So many things are newly coming up. So with that, I think we can straight away go for cases. We are, waiting for sir to join, because I'm itching and waiting for Subhash Kaul sir to join. Please let us know the moment he joins.
yes, sir. Yes, sir.
Take the first case, as sir always says, let me quote him before I take up this program. He always says that the evidence from randomized controlled trials, they give us guidelines, but guidelines will not apply to a single case, because we learn from case to case. That's why one of the famous saying is that Dr. Adams, he writes, you learn neurology stroke by stroke, he writes. So we all learn neurology stroke by stroke. We are actually learning. So with that introduction, we'll take to the case. Let us break out the first case on the platform. Sir, can you welcome the first speaker to
Yeah,
present this case?
yeah. So Dr. Govinda will be the
Sir,
first
thank you
speaker.
very much for joining us, Dr. Govinda. We are
I think
excited
Subhash Kaul
to
sir is
listen
coming.
to
Subhash Kaul sir is coming. So
Oh,
I'm just
lovely. Then,
admitting.
sir, let him give the introduction and then we can take over, really.
Yeah, yeah. So I just
We should not
admitted,
miss out
sir.
on that.
I could see, I think. Yes, sir has joined. Sir, good evening, sir. Welcome. We were waiting for
Sir,
you.
namaste, sir. Waiting to listen from you, sir.
Sir, you are muted.
Please carry on. I was caught somewhere, but now
No,
I'm
no,
free.
sir.
Please carry on.
Not yet. No, not yet started, sir. Please
Yeah,
give your
please.
introduction. We will start, sir.
So
Please.
let us start it without any delay.
Okay, sir. Okay.
So, good evening, sir. Good evening, all of you. So, myself, Dr. Govinda. So, I'm presenting two clinical cases. So, before going to show my slideshow, so I'm very thankful to this MQ Pharmaceuticals and No Thrombosis team for organizing this wonderful platform, for creating opportunities to young neurologists like us to share our cases with eminent stroke specialists. Thank you very much for MQ team. So now I will share this my PowerPoint presentation. So can you see my slides in PowerPoint more?
Yes, we can see.
Thank you very much. So I will. So I am presenting two clinical cases. I just mentioned this faith, affordability, availability. Will are going to know while I'm presenting the cases why I have mentioned which changed the line of management of my two cases. So my first patient is a 45 years old gentleman, Mr. S, belongs to Nirmal district. He is educated up to 12th standard and practicing as a teacher. So he is a known case of epilepsy on Eptoin, no other personal addictions like and no systemic diseases other than the sedentary lifestyle and good dietary habits. So he on the day of presentations he wake up at 5:30 a.m. So after 30 minutes, while he was prepared to go outside, so he could not able to move his left upper and lower limbs. and he fell on his left side. And he was also feeling tingling numbness sensations on his left side, and his speech was slurred with a deviation of angle of mouth to the right side. So he being a teacher and educated, and he was just hardly 30 minutes away from the hospital, but he took almost 5 hours to reach our neuro emergency with complete left hemiplegia, left UMN facial weakness, left sensory loss with tingling and numbness symptoms. With this, his NHS was that presentation was 14. So in general physical examination, his pulse rate was 90, and that was irregular. Some missed beats are there, and his blood pressure was also 200 by 120 mm of mercury on the higher side. So other than this, rest of the general physical examination was normal. So I localized to the right MCA territory, and it's being the dense hemiplegia, I just localized to the right gangliocapsular region. So I just directly advised for MRI brain, MRI angio. So even though affordability issues are there, just because he is out of clinical window periods, I just want to know that there is a salvageable tissue and diffusion flare mismatch. So before sending the patient for MRI, I just send his blood chemistry, and I just screen for all contraindications for IVT for which there are no contraindications. So this was the diffusion sequence, which showed that there is a diffusion restrictions at the putamen posterior limb of the internal capsule and the periventricular region. And corresponding ADC sequence, if I see, there is a mismatch in the same putamen internal capsule and periventricular region. If you, when I see this is the flare sequence, which was not showing any hyperintensities in the same areas. So there is definitely diffusion flare mismatch is there. So which is which I'm happy for that I can thrombolize. So there is no blooming and hemorrhagic any chronic microbleeds. So that also I'm happy for I can go for thrombolysis. And if you look at this angio sequence, there is a right M1 cutoff without any ICAD, ECAD changes. If you look at this neck angio also, so there was the rest of these this ICA anterior and posterior circulations was normal. So present onset is at 6 a.m. and after 5 hours, there is onset to door is 5 hours. They presented at 11 a.m. So another 30 minutes for taking the imaging. So now the management part was regarding this IVT as well as EVT. So there is no doubt about these recommendations with class 1 recommendations and level A evidence. So I can do the thrombolysis and even if mechanical thrombectomy is being considered. So if you look into this blood biochemistry, so the platelet was normal, and there is metabolic parameters were also normal. INR was 1.1. So I reduced his blood pressure to less than 180 by 110 using laboratory. Then I proceeded with thrombolysis using Tenecteplase 0.25 mg per kg. At 11:35, that is onset to needle time was 5 hours 35 minutes. Along with this, I just loaded with atorvastatin 80 mg. So post-IVT, neurodeficits were reassessed at each 15 minutes gap along with this vitals monitoring. So even though he had partial recovery at 15 minutes, after 30 minutes, his analysis was improved from 14 to 4 with gained power of 4/5 in both his left upper lower limbs, and sensory symptoms improved and speech improved with decreased facial weakness. His ECG was showing atrial fibrillation. In the general physical examination was also there is missed beats. ECG confirmed the atrial fibrillation. And echo showed this severe MS and left atrial enlargement. So with this, we know that he's a good candidate for MT. Even if the vessel, in case if the vessel is not yet open, no MT facilities. But the problem was availability problem. There is no mechanical thrombectomy facility around 300 kilometer circle around where I'm practicing. So, and the family members are also very happy about that the patient was significantly improved. And when they came to me when I was speaking about this referral to the comprehensive stroke center, so they're not ready for that, and they said that we are not affordable and we are not willing to go from here. So whatever you can do, you just do. So with this, I just want to ask this Meenakshi Sundaram sir for his expert's opinion. What you are going to do? So in this scenario, so the patient is a clear-cut case of right MCA stroke post thrombolysis. So with LVO, so who are not affordable and not willing to go for mechanical thrombectomy. What best you can do? What is your next step? I just
Sir,
want
we
to open the
always
panel
learn
discussion.
from Kaul, sir. Sir, he is our boss. He will teach us, sir.
Sir,
No. Did you already thrombolize him with intravenous?
Yes,
Yes,
sir.
sir.
IV Tenecteplase was given 0.25 mg per kg at 5 hours 35 minutes from the onset of symptoms.
And he is not affordable for MT at all.
He is not at all affordable for MT at all, sir. And
he doesn't have facility also 300 kilometers from his area.
so the
No, then you have to. I mean, according to me, then you have to let go that option. Once he's not affordable, then what can you do? I mean, I don't know what Meenakshi will
Dr.
have any
Govinda,
other opinion.
yes, sir, same thing, sir. Dr. Govinda, the Bruce Campbell data, it showed that patients who are given Tenecteplase, a good 22% of them as against 10% with the Altiplase, they did not require mechanical thrombectomy. So that's, it saves them from going for mechanical thrombectomy. We have no other option to let it go. But the way you have presented, it appears to me that this patient has significantly become better. And in a center where mechanical thrombectomy is available, you must take them to the cath lab and you must see them. You should not hesitate to do it, even if the patient has become better. But in a center where it is not available, then we do not have to worry. Even if the vessel is, you do not know the status of the vessel, you must go for mechanical. So if they are not available, you just wait and you can always see, you'll be happy. We'll be even doubly more happy if you do a CT angio and demonstrate that it has actually opened up. You can do a repeat. In our hospital, we extend and again another MRI we do in the same chart and we try to see that. That's all. So we'd like to know from you what you have done, Dr.
Yes,
Govind.
what
Anything
actually
totally
happened?
different? Yeah.
So actually, I'm speaking in front of the eminent stroke specialist whose age is whose practice is even more than my age. So there is nothing more I can say what you have explained, sir. So regarding this EVT, so this is a routine care for patients with anterior circulation acute ischemic stroke with LVO, and this is performed only in comprehensive stroke centers. And but in many of places of our country as well as in many countries, but the first contact point of majority of the stroke patient is primary stroke centers, and the eligible patient needs to be transferred to the CSC for EVT. So like Sir Meenakshi sir pointed out that regarding this repeat imaging after IVT, so this provides information on changes about these changes in aspect, thrombus migration, recanalization, intracranial hemorrhage after IVT, and if you could be able to demonstrate this recanalization, such findings may result in the decision to refrain from the EVT, and this reduces the number of futile diagnostic angiographies and associated risks of these procedures like femoral artery dissections, thromboembolic complications, anesthetic complications. Avoiding unnecessary EVT procedures reduces the healthcare cost. So repeat imaging after IVT. So the negative side of this repeat imaging was it itself adds the healthcare cost and increases the contrast medium exposure for patients. And performing additional imaging delays the treatment, actual treatment which are supposed to do, like sir point stressed, which can negatively affect the prognosis of the patients. So this study, one study which was done in Amsterdam, Netherlands, to demonstrate the yield of this repeat imaging among the patients who are transferred to the comprehensive stroke center for the EVT procedures. So they screened 677 patients who are transferred for EVT to their center, and after exclusion, 551 patients are divided into repeat imaging group as 165 and no repeat imaging group is 386. This is the baseline characters of these data. So I just highlighted like few lines, so which may helpful to know that who are the patients who are get benefited, who are possibly likely to get recanalized, whose EVT decisions may be reframed. So is like one is the coronary artery events are less in the repeat imaging group, and the NHS scores at the PSC as well as CSC. Both these comprehensive stroke centers are lesser in the repeat imaging group. So ICA M1 division stenosis is same equally distributed in both the groups, but M2 proximal M2 is more 19% versus 10% in the repeat imaging group versus no repeat imaging. So if you look into this, only the repeat imaging group who are in whom repeating imaging has been done, half of them are show the clinical improvement and 1/4 of them are clinical deterioration, even which the repeating imaging has been done. So the conclusion of this study was the repeat imaging. This was actually out of these 551 patients where this study was conducted, 30% of them with repeat neuroimaging has been done, but that resulted in a median treatment delay of 20 minutes. So in those with clinical improvement, 50% of the repeat imaging group, more than half of these patients with LVO had resolved and resulting in refrainment from the EVT. So about this deterioration group, so the no spontaneous ICS were detected and repeat imaging rarely changed the indication for EVT. So with this, so my patient comes to this first group where we showed this clinical improvement. I just repeated his MRI brain, so which the flare sequences shows that so there is flare sequences didn't show any show the infarct at this right putamen regions. Other than this, there is no larger impact which corresponds to the M1 cutoff. So disproportionate to the M1 cutoff. So the SW sequences also didn't show any hemorrhagic transformation, with which I am happy. I just want to go with this angio sequences, which shows that there is a complete recanalization of these M1, which show good flow in the M2 and M3, or both superior and inferior division, and then smaller branches of this right MCA. So after which, here the story didn't end it. So after 24 hours of this, everyone is happy with the complete recanalization. So I just referred the decision of EBT in this case. So after 24 hours, I just started him on single antiplatelet, ecosprin. So I discharged him on day 3 with single antiplatelets, because this is the area where I cannot keep the stable patients. So because of affordability issues until I just completely managed the patient. I just advised him to follow up at day 7 to start anticoagulants. He came on day 7, but he said that so he on day 6 he had the same territory, same left-sided mild weakness on day 6, which was again completely improved within few minutes. So I just didn't stop the switch from this. The problem is, so I just want to start on vitamin K antagonist here, but the problem is reliable and timely monitoring is the problem. I just started him on warfarin. So here I just want to call, sir, that one question, that is there any way, patients you have seen that near oral anticoagulants has been started in valvular heart disease with AF as a stroke secondary prophylaxis. Before saying in opinion, sir, but I just seen that one patient who came to me. So initially the 2D echo was not showing any valvular heart disease AF with I considered thought like non-valvular. I just started on novel oral anticoagulants. Later I came to know that so his 2D echo was showing valvular, but even then I didn't stop and just followed it up for like 1.5 years, which who didn't deteriorate. So even though the guidelines didn't tell you to start this newer non-vitamin K antagonist, what is your expert opinions? I just
No, yeah, I think, well, thanks for that question. First, I was just interested in your re-imaging of this patient. And you showed that there's a recanalization. But you knew, I mean, if I was in your place, probably I would not have done even the repeat imaging. Why? Because suppose if it had not recanalized, still we would not have been able to do anything in this patient, because it was anyway out of question. So we actually added to his costs by doing the MRI. Because suppose if it was blocked, you would not have been able to do mechanical, because that was not available. Patient did not have money. So, but only thing is that we have added to our knowledge that Tenecteplase can do recanalization. But as far as patient is concerned, whether the, I mean, so my question, I mean, I hope you understand. Even if it had showed
sir,
a,
yes, sir. Yes, sir.
because no, just
Okay,
just listen to me first.
Okay, sir.
Just listen to me. When there's a general tenet that whenever we do any investigation, we should know how it is going to help the patient management. Now, in the field of research, that is not a question. That most of the things which are done in research do not immediately help the patient. So that you have repeated the imaging, it's a very good thing for us, because we have learned that Tenecteplase is recanalizing. But for patient, it makes no difference, because even if it was blocked, you could not have recanalized it, because you don't have MT. Patient doesn't have money. So that was my first question. What motivated you to do the repeat imaging? Why did you do that? Number one. As far as your second question is concerned about this, you see, the reason why NOACs are not used in valvular atrial fibrillation is because these valvular atrial fibrillations of rheumatic heart disease are very uncommon in Western countries. And all these trials were done in Western countries. So those patients were not included in the trials. And it was also thought that it is not based on the other experimental data and other data. It was thought that NOACs are not potent enough, as potent as warfarin, to dislodge or prevent the clots on the rough surfaces of metallic valves or even the rheumatic valve. That's why. But there was a Relay India trial. That was the Indian component of the Dabigatran trial. And there were some rheumatic heart disease patients in that. So there is definitely a theoretical suggestion that it may work in them also. But it is not in guidelines. I have not given it personally to anyone. But I completely agree with you that an occasional patient may benefit from it. There is some data also from the Relay India trial. But personally, I have not given to anybody. Now, you can ask me my first question, that why did you do the imaging in this patient?
Yes,
with
sir.
what
Yes,
in
sir.
mind? With
Yes,
what
sir.
in mind?
Actually, so
How
in
would
my
it, how would it change your management?
yes, sir. So that's what I'm going to answer, sir. Because I worked in a place that I'm a single doctor and single neurologist based neuro super specialty hospital where there is no ventilator facilities. I was just not so comfortable in a patient that where there is an LVO. So I'm not sure that whether the patient is going to deteriorate after this early improvement. So if there is, so I just discussed with the patient that there is he's a good candidate for MT. So he improved. So I'm happy. But in case if he deteriorate, so there is no answer for that from my side as well as the patient side. So I just discussed that what can we do best in case if you could able to demonstrate. I am also happy that I can keep n number of days until the patient is completely recovered and completely managed. And you are also know that the patient is not going to deteriorate. In case if the patient's relatives are not affordable for lakhs of rupees for the EVT, so but the patients are overjoyously accepted that they want to spend for 4,000 rupees. They want to see whether that the thing was expecting has happened or not. And the other thing, I just want to ask one more question, it's very relevant question. In case if I want to do the repeat
1 minute, 1 minute, 1 minute, 1 minute, sir.
yes.
My question is that suppose if you had found that there was a complete block in this patient and the intravenous thrombolysis had not lysed it, then
Yes, sir.
what would you have done in this patient?
Yes, sir. Yes, sir. That was also there in my mind that in case if the thrombolysis, if the complete recanalization is not happen, I can clearly show that this patient is going to develop larger impact in the due course of time. So that I will be on safer side in explaining the prognosis to the relatives.
Okay.
So
For prognostication,
that was my
correct. I got it. For prognostication.
Yes, sir. Yes, sir. Here I just got one more doubt, sir. This is very relevant doubt. In case if as a plan for the repeat imaging, because if you look into this earlier studies, the imaging has been done at the 30 minutes to the 1 hour time. In case if this is the situations happened again for me where I want to do the repeat imaging, at what early point I can do the repeat imaging? So considering this of life
You
and
know,
effectiveness.
as far as, listen, as far as the guideline, see, there is a, I'll tell you one thing. There are something called guidelines.
Yes.
And it is not practical to carry out those guidelines in each and every hospital of the world, because hospitals vary in their infrastructure and in their staff and in the patient's affordability. So when these guidelines are written, they are written, you know, in keeping in view that this is a complete hospital with all the things which are not available. So if you go by the guidelines, then after you do the intravenous thrombolysis, you don't have to do repeatedly. If you go by guidelines, you have to take the patient to cath lab, right? You have to take the patient to cath lab. In other words, you don't have to wait. That time is over. That used to be 2006 when we used to ask this question, how long you have to wait? You don't have to wait. Once you know there is a block, you give EVT and immediately take the patient to cath lab. Now, it will so happen that in the cath lab, 1/3 will be lucky. You will find that the patient is already recanalized and he will come out of the cath lab. So that waiting period is not there. Now, in your setup, where you don't have cath lab, and you have to find out whether it's a recanalized or not, the answer is same. You don't have to wait. The moment you have given the IV thrombolysis, you just take it to the CVT and do it at time 0, not even waiting for 1 minute. That's the current opinion. Because if the bolus has to lyse it, it will lyse it immediately. It will not wait. It will not wait for 1 hour. By the time 20 million neurons would be dead. Yes. Meenakshi, please, your comments.
The same thing, sir. We are in line with you, sir. Absolutely.
So I just
one comment about the valvular heart disease which you mentioned, sir. See, the point is that we do come across several patients who are on valvular heart disease. They are on anticoagulation. They have stopped, and about a couple of years later, they come to you with stroke. So, because natural history says that even when you stop, it's not that 100% they are going to develop stroke. They have taken the risk. Every one of us would have seen such patients who stopped anticoagulation for 1 year and then came with stroke. Now, giving an valvular heart disease patient NOAC, the novel anticoagulant, is like stopping the anticoagulation, because the studies have said that number one, the jet stream effect created in these valvular heart disease patients make these medications less reliable for treatment. It is not effective. And number two, it also says that there is a higher risk of hemorrhage in patients who are using NOACs as compared to warfarin in patients who have got a valvular heart disease. So normally we are saying giving a drug which is ineffective, we are also exposing the patient to have a higher hemorrhage. So it cannot be considered. Luckily, your patient has been on NOAC and nothing has happened. Probably he belongs to one of those lucky patients who stopped anticoagulation for a couple of years and nothing happened. He belongs to one of those categories, I believe. So we cannot take it as a recommendation as of now to accept and NOAC in a patient who's got valvular heart disease. This would be my humble suggestion, sir.
Yeah,
Anyway,
I agree.
Counselor can tell us really.
No, I completely agree that for rheumatic heart disease, we should not give NOAC. For mechanical heart disease, rheumatic heart disease, we should give it only where it has been tested. And it has been tested in non-valvular atrial fibrillation. That's all. So I agree with you.
When dabigatran was tested, 110 twice daily, 220 times daily, 330, 440, and 550 twice daily of dabigatran. You can just believe this dose in the studies which you see, and they were ineffective. So, in other words, the hiking of the dose was not rewarded in terms of stroke prevention when they were treated for valvular heart disease. So, there should be something much more than what meets our eye in terms of efficacy in patients who have got valvular versus non-valvular atrial fibrillation when it comes to the utilization of the normal anticoagulants. So something much more should be there, which we don't understand as of now. As of now, I do not believe that we can use NOACs until more evidence actually emerges. The only area which has been really of benefit is a patient, as you mentioned, a bioprosthetic valve has been placed. And in these patients, for a short time, they are given anticoagulation, only for a short time till such time the valve sets in. In that very short time, dabigatran has shown some benefit in that very short window, but not in any other valvular heart disease setting. It has been of proven benefit. This is my opinion, sir.
Yes.
Okay, sir. So I just
But what I told you in that Relay India, that means the Indian component, there were some patients, but that does not mean that it's in guideline. There were just some few percentage of patients who had received dabigatran, and obviously that company, who makes dabigatran would always repeatedly highlight that point, and they would not ask us to use that, but they would highlight that point repeatedly that it has been used even in this also, giving the indirect message that you may use it. But obviously, it is not in any recommendation. It's not anywhere. So we should resist doing that. Yeah.
When the patient came on day 7, so as he was mentioned that on a day earlier to it, on day 6, as he's having some slight weakness of his left upper and lower limbs, which improved within minutes. Instead of switching from ecosprin to warfarin, I just continued warfarin to ecosprin until BME has been done, which was 2 months after it. So then I shifted him to warfarin. So patient is a known case of seizure on aptoin. So at the time of presentations, which I changed it to levetiracetam. So after 1 month after BME, he presented with the seizures to me. So I was just worried about the hemorrhagic stroke where I have done his CT brain. So luckily we didn't reveal any hemorrhagic transformation. So I was just happy with this. So I just continued. NCCT brain didn't reveal any such bleed. So actually, I just had requested for MRI, which they could not do. So I just optimized his AED, considering this as one of his post-stroke seizures. Now he's fine at 4 months follow-up with MRS 0 on warfarin and atorvastatin. So with this, I just end my first case. So I just want to show you the similar case in a short way. So the second patient is 60 years old, Mr. B, with no family history of the stroke. He's with chronic heavy alcoholic non-compliance to the antiplatelets, which he advised earlier, and he's a farmer, not in sedentary lifestyle. So he has hypertension on irregular treatment. He had a stroke which was 5 months back with near complete recovery and not traumatized. So he was brought in altered sensorium state, drowsy state, right hemiplegia. He was just not moving his right upper lower limbs onto the deep pain. And onset is 9, and he came to the hospital within 1 hour. I did his MRI. So diffusion sequences was showing this restricted diffusions in the left side in the insular, frontal, and temporal opercular regions. So and ADC sequences is also showing this diffusion ADC mismatch in the same area. So the flare sequences was not showing any hyperintensities in the corresponding areas, but it was there is an gliosis and encephalomalacia with volume loss and this occipital horn enlargement. So SWA sequence was also done, which I couldn't show here as I didn't get those sequences, but which was not showing any hemorrhagic transformation, which I will show in the later. So and angio sequences shows that his left M1 cut off. So the rest of these anterior circulations was not vasculature was normal. So his neck angio was showing some ECAT changes. Other than this, there is no significant stenosis in ICA as well as these vertebral arteries. So I just explained the risks and benefits to the group of 8 family members. I just explained in favor of IVT as I want to thrombolysis. Along with the possible further requirement of MT, I just stressed so much that this patient, considering having these multiple vascular risk factors and these addictions, and so I just stressed regarding this, he may, about the recanalization rates are very low. He may or may not recanalize. So with this, I just, as given the consent for thrombolysis, as I proceeded with thrombolysis again with Tenecteplase, but with 0.2 mg per kg in this case, with onset to needle time is 1.5 hours. So the patient's sensorium is slightly improved, even with no significant improvement in power post thrombolysis. So I just explained the relatives that he's a good candidate for MT. He needs to be transferred to the comprehensive stroke center, sir. Here is also the same issue. They're not affordable and not willing, but along with this affordability and availability issues, here the faith issue is also issue there. So again, the relatives has been changed. Some new group of relatives came and they're questioning me that why you have thrombolyzed, so we should have directly go for thrombectomy. Even though on the other side they're saying that we are not affordable for thrombectomy. This is the scenario. So where so as they could not pick up with a rapid best decision, again I just considered for MR angio group. I just considered this patient as the second scenario for the repeat imaging paper. So where the patient is not improved, and I just proceeding for this repeat imaging. So I just this is the flare sequences, which shows that didn't show any impact developed at the corresponding any major impact that was developed. So still, I was happy that still there is a salvageable brain tissue, and this is the SW sequence, which was not showing any blooming either in this newly affected area or the previously affected impact area. And the angio sequence was also not showed up any recanalization. So I was just unhappy, but I'm sure that this patient needs to be immediately shifted and this patient is going to worsen. I just don't want to keep the patient in my hospital. So as I just thought that he's going to be worsening. So I refer, and that too, he's going to get benefit with MT. I just insisted, despite of explaining to the relatives, they are so adamant that we are not affordable, we are not going to take him. So after 5 hours, they are accepted. Again, they took another 2 hours. So they finally referred to the comprehensive stroke centers at 7 hours from the onset of the stroke. So, but this is when I just followed the patients, but they reached to a different hospital where there is no facility for MT, and that too after crossing the 24 hours, where he was managed conservatively. But luckily, he didn't worsen and didn't require any decompressive hemicraniectomy like the mass effect and DCH. So he discharged with MRS 4 to 5. So I just want to ask the panel members, so after finishing my slides, that so what best I could have done in this patient so that the prognosis should have been changed. So the take-home messages in my presentation was, it's challenging to practice at a place where you know the guidelines but you cannot apply. So we are missing patients to get benefit even the reaching time. Holds true for IVT as well as EVT. Better knowledge and awareness in the society may change the practice. So in my practice, so here it's very painful for me but helpless when I'm not able to thrombolyze acute ischemic stroke patients who are in window period, managing day 1 acute ischemic stroke without knowing the brain angio. So as they're not affordable, not going for benefit of MT when they're supposed to go. So I just presented these 2 cases showing the repeat imaging helped me about the next valuable ethical step in these 2 cases, even though, so these are not the actual guidelines. So thank you very much. These are the last 2-3 slides which I'm showing, which are not relevant. So which were published in the last month only. So this is the angle aspect with the larger impact cases, like with aspect of 3 to 4, where the it was showing that benefit of this EVT. Even though it was showing that safety, there is issue with the safety outcomes like more of symptomatic ICH, intracranial ICH, but death rate was similar. But this was showing the good outcomes in terms of these MRS, the excellent functional outcome 69 versus 26, and the good functional outcome 108 versus 75, and the NHS score of 0 to 1 or more than 10 points improvement. Baseline, in fact, core volume was also less changed in the EVT group, even though the patients are larger. In fact, this study was the Angel aspect study, as well as the second study was selected to study. This Angel aspect study with Altiplace, but the selected to study with this Tenecteplase is the global study. The previous study was the Chinese study, but this is a global study conducted in the US, Canada, Europe, Australia, New Zealand. So this is also the larger, in fact, with the aspect of 3 to 4, which so with this, I just concluded my talk. So thank you very much, sir. So I just open the panel discussion.
Well, Meenakshi, you want to make any comment?
Sir, one doubt I had regarding the first case itself, sir. I was not sure why aspirin was given for that patient, sir, in a mitral valve disease. Is that okay, sir?
No, it doesn't have any role, but probably because he can answer the question, Dr. Govind.
I just given as a secondary prophylaxis only, sir. But day 2 after 24 hours, I just want to start him on anticoagulations. And the discussion was going on regarding this. I just could not able to get the benefit of the MT. I just thought that he may show this embolic shower. So I just want to keep him on the low dose of ecosprin. I just started him on 75 mg.
I think that is okay. I think that is okay because he probably, I understand you wanted to wait because, you know, there was a risk of hemorrhage by giving warfarin on the day 2 or day 3. So till that time you wanted to cover with ecosprin, even though the cover will not be as much as warfarin, but at least something is better than nothing. That it was in your mind. So yes, that is okay. Now, you see, as far as the, no, because one point I want to make here that in non-valvular atrial fibrillation, it's not that aspirin has no role. It can be given, but it has very little role. So, for instance, if you give warfarin or NOACs, the protection relative risk reduction is more than 70% now. But with aspirin, this is 20 to 30%. So, something is better than nothing. If you cannot give other anticoagulants, you can give aspirin. I think that's okay. But we want to give, you know, what benefits the patient maximum, which is oral anticoagulant. So, I don't think that was a mistake to give it. That is fine. That is perfect. I would have done that. Now, regarding your other question, which is important question, that what should you do in a remote area? I think I would do the same what you did, except probably the repeat imaging. I would do the I would do the repeat imaging only if I knew that based on that repeat imaging, I can take a decision, right? Because patient only has to pay for the repeat imaging. Once I know, then I will counsel him without the repeat imaging. That look, we are doing our best for it. But further investigations are not possible for you. You can go to the city, but that is going to cost you a lot of money. And again, the benefit is not guaranteed there. This counseling is very important. You know, counseling is, the top doctors finally do counseling. Whenever I have met Dr. Singhal, today Dr. Singhal, out of half an hour with a patient, 20 minutes he spends in counseling. Because making a patient understand is very important. He has to understand the limitations. It is not possible that every patient will be able to afford every treatment. You have to be realistic. It is not possible. And it is only the government which can make it possible. And government is trying to work on this. Actually, it has already come in the government of India, this national program of prevention of and treatment of stroke and all, but it has not yet been implemented at each and every place. In some states, like in Himachal Pradesh and all, in a limited set, it has been implemented. In that, the model is that the stroke detection begins from the primary health center. Then the primary health center contacts the district hospital center. Then the district person connects with the tertiary center, and the patient does not have to pay 1 paisa also. That affordability question doesn't arise only. Those systems government has contemplated and implementing in some places, but not able to do it because the country is so vast, so broad, so big, that how can you reach each and every? But that is the aim. That is something which is happening in Canada. That's what is happening in Australia. That the patient doesn't have to worry that he cannot afford me. It's only in our country. So in our country, I think there's a clear gap between people who can afford and people who cannot afford. And the people who cannot afford, it is the government which is trying to help them. As far as you are concerned, I think you are doing the right thing. Give them intravenous thrombolysis. If they cannot afford mechanical, stop at that time. Stop getting stressed at that point in time. Till the government system is such that there will be district, we have had many meetings on that also, district endovascular centers. At that time, you can send to them. Till that time, you cannot do anything. Patient has to be able to afford it. And that is one thing. And second thing is that as far as the window period is concerned, now it is up to 24 hours. So the patients who are able to afford, they can, if they are able to afford, you can even refer them at 12 hours, 13 hours, because sometimes it takes them time to arrange money. In fact, I do that in my hospital. I'm in contact with some district doctors, and sometimes they are able to refer and sometimes they are not able to refer. And one more very important thing is that every patient, just because he has got a stroke, does not mean that he will benefit for mechanical thrombectomy. Mechanical thrombectomy has a significant morbidity and mortality. They also can bleed. They may not respond at all. So don't think that mechanical thrombectomy is the after 16 hours, the core has to be 1/10 of the MCI, not 1/3, 1/10. That means 20 cc core, 30 cc core. That 30 cc is small. So if you see that your patient is having 1/3 of MCA is involved and patient has crossed 12 or 13 hours, no need to shift him. At the time your CT scan. So I think the most important thing for stroke management fundamentally is CT scan brain. That is it. 80%, 90% of strokes you can treat if all you have is a simple CT scan. Decisions you can take by the CT. So that is what I would say. And Meenakshi, please, your expert comments.
Thank you, sir. Dr. Govinda, really
Yes,
phenomenal. See, we can talk from cities with all facilities that you have done in a place which you told us that it doesn't have an empty facility and you are boldly doing it. I don't think you should be discouraged. Beautifully you have done.
Not at all. Not at all. We are very impressed with what you have done.
Impressive. And
but
you
I
have
just
presented a case where it was not successful. The courage of a person is to tell a case where you were not successful. Not that everything is rosy to us. We also face these issues and nothing works really. In fact, one important point which we learned in our own center, there is a place nearby our place called Karikudi, where Dr. Tirupati is a physician. Dr. Priyanka, who is the other presenter, she knows about him. He thrombolyzes more number of cases than we do. Smaller the center, easier the thrombolysis because more will be the understanding. The family will understand. They think that this is the अपना doctor है. ये गलत नहीं कहेगा. The moment they go to a bigger center, they are also having a clouded judgment that no, something is there. This is a big hospital. They may have hidden agenda. In fact, it's wonderful you are doing it. A couple of points there. In our hospital, for instance, when they present within 3 hours, I do not go for MRI at all. Number one, it will cloud our judgment. The moment you see large infarct, even when you thrombolyze, we always say we should do it with a positive spirit. I have seen many people be negatively go and give an IV line. Whether you believe it or not, our vibrations also count. For instance, the MRI which you showed, the aspects was quite poor. It was less than 6, sure, right?
yes,
The
sir.
aspects was 6
No,
or
sir.
less, I should say. Huh?
No, sir. Good aspect, sir, in both the cases.
Good aspects? Okay,
Uh,
maybe I was wrong. Because I thought the M4, M5, M6 was gone and Insula
No,
was also gone in that case.
no, sir.
Good aspects?
Good
Then
aspect, sir, in
maybe
both the
I'm
cases.
wrong. Okay. So one important thing which we decided in our hospital is less than 3 hours. We will not do MRI. Now that even Tenecteplase has gone, we'll stick with CT. Because it's such a simple thing. It finishes things for us within a couple of minutes. And we can go and just give the IV thrombolysis in a CT room. It is much more accessible than an MRI room. So less than 3 hours save time first.
Yeah.
And we have created a protocol where Dr. Nandi knows that if the patient pays only once, he will get a CT or an MRI based on what is requirement. Only one charge will be there. And in fact, even for the repeat scans, sometimes we do get it when we are challenged with the the relatives saying no, yes, they're double-minded to demonstrate, we do that. But the patient will not pay again. Only one charge he pays. And then whatever scan he does at the time, it is done for us. Just to learn, we do it without wasting time, definitely. This is one thing which we have done in our hospital. It has been successful so far, but less than 3 hours, we always stick to this because it will create no hassles in our mind. Straight away we do it and we just give it. And then we can always sit and think the patient does not pay for an extra seat in our hospital. They pay for only MRI, CT is just done as a free, it's an accessory. It comes 1 + 1. This one that always creates easy things. That's what we have done. But when they cannot afford further, we can't do anything. And you were also frustrated with a relative who later on came and fought. Dr. Nandini knows what we do in our hospital. What we do is that we have a place where it is video record. And we most of the times I tell them, the family, when they come, I tell them, you take a recording of whatever I'm going to say. And then you tell them the time. This is what I have said now. And they also should know that you have a video recording. That where we enter our hospital to emergency, there's a small call, that's a foyer kind. In that foyer, we have placed a video camera. And I always tell the family, whatever I want to talk to you, make a video in your recording or you take an audio. So that this thing will never happen. It will save a lot of time for you. Then they
Yes,
cannot
sir.
say, no, we have not said that. And they should be knowing that you have also recorded, unless they know that they will create trouble for you. Doesn't happen in every case. Most patients will accept. Once I was aggressive and calls I said, don't be aggressive. You should be soft to patients. That's what he taught me once. Let us be soft to them, but always let them know that you have a recording and they have a recording. They will never come and fight with you. Trust me.
Yes, sir.
So I
So
have
actually,
2 points. No, okay, please carry on. Carry on, Govinda.
yes, sir. So actually, my OPD where I'm sitting and doing seeing all the patients is attached with audio video recording, sir. So where in which I just explained everything. So that was the confidence that I have the proper recordings of the what I have been explained to them. So I was just like you said, I was just so soft and so patient. So when there are different group of people came and then explained me the all these things, other things. So the other thing which you pointed out regarding the second patients where I have done this MRI, even though the patient was came at 1 hour, is the reason behind it was the patient was having this previous history of the stroke and they have no proper documents. Even though they mentioned that so they have taken this clopidogrel, so icosapent clopidogrel which they have discontinued. So and the other thing was I just want to and in my scenario, if I do my CT scan, so I didn't have any CT angio attached with it. I don't know the vessel status, because of which I just want to know the angiostatus vessels, large vessel occlusion in this patient. And other than that, what is the status of this previous impact? Whether there is any CMBs, whether I can thrombolize this patient? Because majority of the patients, 99.99 patients, I do CT only. But in these patients, because of these situations, I just proceeded with MRIs.
Now, I want to make, yeah, please,
No, no, sir. No,
SMS.
sir. No, sir. Sir,
No,
no,
please
no.
finish your, no,
Sir,
please your
no,
comment,
sir.
please.
Sir, no way, sir.
Okay.
Please, sir.
Yeah, no, you see, most of the research which has been done on CT scan.
Yes, sir.
In none of the stroke clinical trials, cerebral micro bleeds have to be taken into consideration. It is just because we know they are there. Therefore, if they are more than 10, we don't want to give it. Otherwise, you are not required to even check for micro bleeds. So don't worry about it. CT scan is good enough, and we need not think about it. But of course, MRI is helpful after we have crossed 4.5 hours. Up to that time, we should not even bother about it. Number second is my very seriously, I believe we should not waste time on consent and all. Those days are gone. We are not in 1998 or the year 2000 when we used to make such a big issue about this consent, and the patient would take 3 hours to give consent, and he would call all his relatives in Gulf and New Zealand and America, and then cousins would tell whether to give or not, and then we would tell him you have got only 5 minutes left. After that, the window will close. Those days are immature days. Those are gone. Now, very professionally, we should tell patient, look, there is this treatment. This is the only treatment available. There's a side effect of bleeding. Do you want it or not? He will say yes or no. That is it. No more. You should not. No doctor should spend more than 2 minutes on consent, and it should be immediately. We should really waste time on consent. You actually don't need to take the consent because it is now a standard of care. But I would not encourage that. Take a consent, but take it very professionally, very urgently, and don't waste time on that. Other thing I want to tell you is that it is not that thrombolysis is the only answer to stroke management. If you look at the thrombolysis data, it, spontaneously, if you do nothing to a patient, 30% of them will become normal. If you do nothing, if you give nothing, not even aspirin, 30% of them will become normal at 3 months. When you give IV thrombolysis, that 30 figure becomes 43, not 100. You have only added 13 more patients. So therefore, it is not just thrombolysis. It is the overall other things also. If you cannot do mechanical thrombectomy, it does not matter. You can do so many. You can check glucose. You can check hypertension. You can check fever. You can look at cerebral edema. In fact, you must be aware of a protocol called FES protocol, in which they are looking at fever, swallowing, and sugars. And it is found that if you do FES protocol by nurses, the outcome is much better than even the thrombolysis. The number needed to treat is much better. It is some 6 or 7, whereas in thrombolysis it's 10. So therefore, we should not think that, oh, if we cannot thrombolyze, therefore, no. The temperature makes a very big difference. Sugar makes a very big difference. Prevention of bed sores makes a very big difference. All those things are not just like that. So what I'm saying is basically that we should not just depend on one thing and think that it is this or nothing else. Those things are also important. So there is still a lot of scope of stroke management at the district levels. And the other interesting thing is that both your patients received Tenecteplase, right?
Yes, sir.
Both.
Yes, sir. Yes, sir. Tenecteplase.
So the,
But
so
first
the
phase
take,
was
so no,
0.25.
listen. Let me give the take-home message. So the take-home message from this is that in 50% there was recanalization, in 50% there was not. So
Yes, sir.
that's a very, of course the Tenecteplase people can protest that no, the sample size was too small. Probably if we had 40 patients, then maybe 80% would have recanalization. But in this sample, this small sample of 2 patients, there was a 50% recanalization. 50% did not recanalize. Meenakshi, over to you.
Perfect, sir. Thank you very much, sir. Dr. Govinda, still as sir was saying, no, it has still not given me an idea as to what MRI has done against CT. If you knew a large vessel, what would have done? Anyway, you don't have a mechanical thrombectomy facility. And secondly, even if there was a 5 months ago, there was a hemorrhage, with this stroke, would you have said no to thrombolysis? Is 5 months post-stroke is in the contract, and the patient has received aspirin clopidogrel, you said. So I still feel that we should stay with CT because it will convince us to do things fast. The only parameter which has made any difference in terms of NNT or all the stroke trials is the time to thrombolysis. It is the most crucial thing. As I mentioned, Tirupati, this one, their success rates, Dr. Tirupati has thrombolyzed almost 200 cases. Their success rate is phenomenal. It's a very smaller city, much compared to our Madurai. Our Madurai is not a big city. It's a good, big city. So it's not a great city. Hyderabad, if you take Madurai, will be 120th maybe. But Tirupati thrombolyzing in Karaikudi, which will be maybe 1/2 of Madurai. Their success rates is double than our success rate because of that one simple factor. CT thrombolysis, CT, they don't even have an MRI, CT thrombolysis. And very quick, the patients reach fast, they do it fast, and their rates are much better when compared. Their success rate is phenomenal. So
I think they have.
feel
I
that
think they have given Tenecteplase even before it was licensed or registered, right? Some
Yes,
200-300 patients
yes.
they have done.
Yes,
Acha, Govinda, your second patient, did he have brain hemorrhage 6 months back?
5 months back,
No,
sir. That was in
ischemia.
5 months back.
It was brain hemorrhage.
No, sir. No, sir.
Ischemia,
In
sir,
fact,
ischemia.
Okay,
Ischemia.
yeah.
He
Ischemia is
said
okay.
that
Yeah,
what
that
it
is
was an
fine.
hemorrhage. In my
Yeah.
opinion, whatever said and done in the ischemic stroke when they have come, I don't think it would have made a difference for us really.
But
One
good
last,
cases, great learning for us and great, exposure to the difficulties faced. We completely appreciate. And in spite of that, you are doing such good work. Yeah, please go ahead.
one last thing I just want to ask you, sir. So I just want to explain a scenario. So in case in your hospital, so in the era of thrombectomy, so only CT is available. CT angio was not available. So do you want to proceed first only CT?
Yes.
In the era
In
of
my
LBO.
yes. No. You are talking in my hospital or in general?
Sir, so in the era of this mechanical thrombectomy, so suppose if the patient comes, you want to do his CT for decide about the thrombolysis. So the CT angio was not there.
No, you see, the ideal thing is patient should have CT and CTN.
And the other thing was patient is affordable for only imaging, one imaging. So you can do CT followed by thrombolysis followed by MRI. So that is also not possible. So do you want
No,
to proceed?
then only CT scan. Only CT scan, nothing else. What Meenakshi said. Only CT scan. Because anyway, after CT scan, our doors are closing because patient is not affordable. So let us not do unnecessary investigation in him. If I am not going to do mechanical thrombectomy, then once I know that this patient cannot do mechanical thrombectomy, I will not do CT angio. Why? As a matter of fact, you may argue for giving double antiplatelets. That's not a problem. Give double antiplatelets for 3 weeks or even 1 month or even 3 months. No problem if you are suspecting, but not beyond 3 months. So CT scan alone is enough. It is the most important thing in a resource limited setting. If you have resources, then you can do anything. Meenakshi, what do you say?
Sir, I think we need to move to the second case. Dr.
Okay.
Sorry,
Priyanka is waiting.
sir,
It's
sorry.
more than an hour's time.
Yeah.
We just presented only one case.
So Nandini, you should
Yeah.
do it very quickly.
Yeah, sure, sir. It's a very
really, inspired us, I must say. Inspiring case by Dr. Govinda. Thank you, sir. Thank you.
Thank you, Govinda.
Thank you.
So good evening, everyone. So thank you for giving me this opportunity. Thank you, speakers and all the moderators and the MCure team. So I'm Dr. Nandini Priyanka. I'm working as a consultant neurologist at Apollo Trichy. So it's a very short case, very short presentation. This person is 50 years old. He came within 1 hour of onset of symptoms with NIHS score 5 of minimal slurring of speech, demeanor dysarthria, and rapid drift in the right upper limb and the right lower limb, with the total score of NIHS 5. And the CT aspect was 10 by 10. So immediately we thrombolized him with injection Tenecteplase of 0.25 mg per kg. This is his initial CT brain, which is almost normal with the aspect score of 10 by 10. But 15 minutes later, his NIHS score was worsened to 11. The weakness got progressed of right upper limb and lower limb. What I thought there could have been bleed, but repeat imaging showed no bleed. So this is we did MRI with MR angio in the next following imaging. Flare, there was no changes in the flare, but this was his DWADC. Only the M2 and M3 cortical territories, there was diffusion mismatch, but MR angio